Hi there.
Well, slowly, it looks like we're getting some people. Ashley, can you tell if other people are trying to log in, sign in, whatever?
Yes, I can tell. As each person enters, I can emit them from the waiting room. So,
So are there some other folks?
let me see. Yes, currently there's no people waiting in the waiting room. So I'm guessing they are still in the process of joining.
Well, let's give it a few more minutes. Okay, I'm going to give it just a few more minutes. I was expecting Judge Friesman to get on. I may text her and see. Okay, Ashley, I'm going to go ahead and call out the people that I see on my screen, and if I don't see somebody for some reason, please let me know. Dr. Oliver is on, Judge Jackson, Dr. Fikes, who's going to be presenting to us, Dr. Wright, Marilyn Leake, Judge Bruton, Ms. Sellers, Judge Porter. Media services must be somebody from Atlanta with BHRIC, Mr. Cranford, and Ms. Dixon. Did I miss anybody? Okay. So we don't have probate judge, we don't have the defense bar, and I'm the only one that's currently here from Superior Court. But I think we have enough to start, and it's 5 after. And everybody's still here, even after the emergency, whatever it was at 2:20 that was supposed to do something horrible, and I didn't even see anything on my phone. So I don't know what happened with all that. So welcome to those of you who are here. We have some work to do today. I'm going to tell you, and there's Miss Button coming on. I'm going to tell you that what my plan is for us to have some recommendations in writing by the end of the year, both for legislation and for other things that can be done non-legislatively. And I can also tell you today that we are just delighted that Dr. Oliver has been promoted, and she is now the forensic director. Hooray! And the forensic director position has been open for years, some long time, 3 years, I thought maybe. So it's very exciting, and she has a lot of good ideas that we are going to be using to help us move forward. And we also have her counterpart, which I think he's her counterpart, Dr. Fikes in Tennessee, here to talk to us about some things that they've been doing. And then I'm going to ask at the end for all of us to sort of take a piece of something that Dr. Oliver is going to talk to us about and do some work on it before the November meeting. So now's the time we're going to get to work, not just sit and listen, but I'm excited for what we can possibly accomplish with doing that. I'm going to turn the meeting over to Marilyn Leake and let you introduce Dr. Fikes and let y'all talk to us about Tennessee and how far they've come.
Thank you, Judge Goslin. It's good to see everyone. Big congrats to Dr. Oliver. That's so exciting.
Yeah.
So I am not going to take up a whole lot of your time. I do have a few slides that outline some things that other states are doing related to outpatient evaluation and restoration. They can get a little bit weedy. So I think maybe the best bet is I'm going to send these to Judge Goslin and you can look at them on your own time, because I don't want to take away from, the main event, which is Dr. Fikes to talk about Tennessee and to hear from Dr. Oliver about Texas and what you all are doing at DBHDD. So I will turn it over to Dr. Jeff Fikes, who's Executive Director at the Office of Forensic and Juvenile Court Services at Tennessee's Department of Mental Health and Substance Abuse Services. Thanks for joining, Dr. Fikes.
Thanks very much. Thanks for having me. And congratulations, Dr. Oliver. Welcome aboard. Look forward to seeing you and hearing from you at future NASHP Forensic Division calls and so forth. I have always had great respect for the level of expertise in forensic work done in Georgia. We took much from their trainings. I've been pleased to attend their forensic evaluator trainings through the years. We share registration invites between when we do our training, when you all do y'all's training. But I'm going to talk to you today more about how the system is set up in Tennessee and how we provide the forensic evaluations and restoration services to maximize the use of community-based services. And focus hospital-based services available whenever they're needed to those people who actually definitely need them, is the concept. Tennessee's laws about forensic evaluations, with what authorizes the courts to order forensic mental health evaluations, had actually been in place in more or less their current form since 1974. They were a reaction to Jackson v. Indiana, when states started figuring out what to do about lengthy hospitalizations of incompetent defendants and so forth. And so that's one of the reasons why it's been, it works kind of smoothly and effectively on the front end as it does. It's just because this is the way it's been for many, many years. The statute says that General Sessions, Circuit, and criminal courts have authority to order mental health evaluations on criminal defendants of their competency to stand trial and mental capacity at the time of the offense. To be conducted on an outpatient basis by an evaluator designated by the commissioner of the department. And so from the get-go, all evaluations are conducted first on an outpatient basis. And they're conducted by evaluators that the department has contracted with, trained, and monitors. So I have contracts with 9 community agencies to cover all the courts in the state of Tennessee. And their evaluators attend our trainings. We do a certification, we have an initial training, and then we have a renewal training where we bring in some nationally known expert every couple of years and expand their forensic knowledge base. They submit their billing monthly to my office, and I have forensic specialists who go through their billing, checking court orders, letters to courts, and data report forms. That allows us to collect data on each evaluation, outcomes, and track trends, and so forth. But it also, that's our blow by blow monitoring of quality and performance of the evaluators. Most of our evaluators have been doing this for a long time, or a new evaluator will join an agency, and that agency has had the contract with a long time, so they're surrounded by people who have some experience with the situations. I encourage communication locally between those agencies and their courts. We have standards for what they have to do in terms of the letters and the paperwork and all that kind of stuff, and turnaround times and all that kind of stuff. But I really support them developing a relationship with their courts and doing what's best for both in their regions and their areas, because that can vary greatly across the state, as you know, between urban and rural areas and so forth, and like that. And these evaluators see the defendants. They can see them via video conference from the jail, or they can go to the jail, or the sheriff can put them in a car and drive them over to the community mental health agency, whatever. And they're conducting an evaluation of their competency to stand trial, mental capacity, timely defense. And then that statute goes on to say that if and only if the outpatient evaluator recommends an inpatient evaluation, may the court order the defendant to be hospitalized for the purpose of further evaluation and treatment for a maximum of 30 days. And so our outpatient evaluators see everybody. So we do about 2,000. The last 2 years have been about 2,300 evaluations per year statewide. And then they make a recommendation to the court. 65%, 70% of them are competent on the front end and do not need to go to a hospital. My contracts with these agencies include a number of things other than just conducting the evaluation. So I can reimburse my providers to see a defendant a couple of more times if they're close to being competent, but not quite competent yet. So another $75 a session for a couple more sessions. If they encounter a defendant who may have started medicine once they've been incarcerated in the jail, but are not quite there yet, they can write the letter to the court to defer the evaluation, come back and see them again. If they need to get referred to mental health services in the jail to get started, they can do that on the front end as well, and do some training that's necessary to get someone ready to go. I mean, basically, we consider it in everybody's interest to get a competent defendant before the court as soon as possible. It's to the advantage of the defendant to get through their criminal justice business so they can get on with their recovery. It's to the benefit of the prosecution to have competent defendants, so any plea bargain agreement or conviction is not overturned, and the court can move the docket more effectively that way as well. Our department is also big into the sequential intercept model type approach to a range of community services across the state. That being that big fancy word for just the idea that as a person encounters the criminal justice system and police, there are a number of points at which the person could be diverted from the criminal justice system into treatment, or at least involved in treatment if they need to stay in the criminal justice system. So we have mobile crisis teams that cover every county in the state. Those are contracts between our Department of Mental Health and community mental health agencies. Quite a few more of contracts there than my 9 that cover forensic evaluations. And I think maybe they have a dozen or something like that that will cover mobile crisis teams. And those crisis teams, it's initial telephone triage service, and then we'll go face-to-face as needed. And they'll do 120,000, 130,000 calls a year, and about half of that face-to-face and so forth. They see people in the jails, emergency rooms, homes, wherever they need to see them. Those agencies also, many of them operate crisis stabilization units. We have 7 now, 4 more coming online. The one in Memphis is going to expand from maybe 12 beds to 30-something beds, things like that. And in Tennessee, there's no legal requirement for a law enforcement officer to stay with a person who's being evaluated for possible emergency commitment. So if they encounter a person in the community they think is experiencing a psychiatric emergency, they can go to the CSU and drop them off. And one of the metrics that we use for monitoring the crisis stabilization units is drop-off time. How long between when the police arrived and when the police left. So that's an advantage as well for getting people. And of course, there's crisis intervention training of the police so that they recognize people who are in mental health crisis. We have in Nashville an increasing co-responder models between the police and the local mental health agency, and EMTs and the local mental health agency as well. And those are very local. The local police department needs to engage with a local community mental health agency. The state supports it, but there's not much you can do from a central office state mental health authority to implement a program like that, besides support and maybe some training, consciousness raising, things like that. But those have to be local initiatives, I think. And then we have another program called Criminal Justice Liaisons. When you're doing other conferences in person or virtual and you hear forensic navigator, think this is probably the same thing. And they'll vary greatly from state to state. New Mexico has them, Colorado has them for different roles and so forth. And in Tennessee, a criminal justice liaison is a person contracted from a community mental health agency to work with the detainees of the local jail. So they develop their own relationship with each sheriff's department. In some of the larger areas, the sheriff, the community mental health agency is contracted with a couple of criminal justice liaisons with money from our department. And then the sheriff has hired a couple more, kind of depending on what their needs are and so forth. And those folks find people who are in the jails who are in need of mental health and substance abuse services, and they can help connect with the person to services when they're prepared to leave the jail. Should they get bonded out? Should they finish their criminal justice business and so forth? But also within the jail, they could identify, yes, this is a person that we have served at our community mental health agency in the past, and now they're in jail, so we're going to let WellPath know. Maybe that's the company the sheriff has contracted with to provide their medical health and mental health services and connect them within the jail. If we get court orders for evaluation and we need some more information for what's going on in jail, we might reach out to the criminal justice liaison. If we have with defendants who've been found incompetent to stand trial and they're back in jail, or they've been found competent to stand trial and they're back in jail, and we want to maintain their competence, the criminal justice liaisons can help make sure the person's connected with the treatment services in the jail. Jails can offer mental health services. If a detainee refuses, there's not much else jail can do at that point. However, criminal justice liaison can use clinical skills. They can go and engage the defendant. They can go and see the defendant. Hey, you're taking medication. Do you having any problems with the nurses? And kind of encourage them to get more involved in treatment. So we use all these kind of resources to communicate with one another as part of the whole system. Where defendants get a court order for evaluation, once the person has penetrated far enough in the criminal justice system to where they're, charged, they're held, and they're going to be prosecuted. So a court is ordering competence evaluations to determine if they're competent to stand trial for the purposes of the prosecution. Now our outpatient evaluators have seen them and have started the process. So like I said, and at this point, I'm going to do a dramatic pause to have a sip of water and encourage people just to unmute and ask me questions, sort of at any point. Say, hey, I didn't hear that, Jeff. Can you repeat that? Or how do you do that? Or just whatever you want to ask.
Good, I have questions. So you said that there's always been the presumption that it'll be outpatient. Does it also say in your statute, jail is outpatient? Does it mention jail at all?
It doesn't mention jail.
Okay.
But
you assume jail is outpatient?
Yes.
Because it's not. Okay.
That's right.
Okay.
So this is in the title where the mental health law is, Title 33.
Okay.
And so outpatient would be anywhere that's not in a treatment resource, which includes a hospital.
Okay. So was Tennessee keeping up with this 30-day timeline throughout the last 3 years?
No. As soon as in March of 2020, when courts started closing and jails started having to either release people on bond or keep people out of the jail, there was initial, first we stopped getting orders for a little while, and then we started getting orders again. We got a bunch of them. And then we had been using video conferencing well before the pandemic because of the many rural areas of the state, where it would take a sheriff an hour to drive one way to a community mental health center, or the community mental health center to drive one way to the jail. So that was helpful, and we were able to do more of that. The outpatient providers caught up quickly. But the inpatient providers, you can't admit but so many people, depending on how many psychologists you have to do your forensic evaluations. In Tennessee, we haven't had much of a problem with actual capacity in our state hospitals for patients. So we've always had space for people.
Okay.
Forensic evaluations are non-emergency admissions. If someone is in need of emergency admission, they can be brought in through the crisis team at any point of the process. The day after they come to jail, when they're waiting for an outpatient evaluator to see them, if referral to inpatient while they're waiting for an inpatient referral thing to happen. If they get to that point, we'll bring them in. And we've always had bed space to bring people in imminently.
Now, when we talked earlier, I think that you said that Tennessee was caught up now.
Yeah, we have been able to catch up in terms of the regional mental health institutes really focused on getting those orders in. They added some psychologists. A lot of times they would contract with the psychologist instead of trying to create a new state position, which is a burden in a lot of ways. They would just contract with services, and that's all that person does is forensic evaluations. And so I train them and certify them and monitor their evaluations just like anybody else. So without adding state positions at the hospitals, they've added evaluators, and that increased their capacity for being able to do more. And then one of the metrics that I did when we were behind was I started counting how many orders each hospital would get during a month. And we actually count them week by week. And so what I would add them up for a month, and I would tell the hospital, you're getting 30 orders a month, which means you need to admit 31 patients a month, or you'll fall behind. And if you really want to catch up, and you want to catch up in 3 months, I can tell you that if you admit 35, you'll catch up in a certain amount of months. So you use data like that to kind of track how many admissions they need per week in order to catch up with their backlog and to keep up with the rate of orders that they're getting.
Okay. Are there some other folks that have questions?
I had a question. I wanted to kind of follow up on what I was hearing here, Doctor. Are you saying, when you say that you're caught up, do you mean that you're caught up with the individuals who've gone into the hospital, or you guys are caught up with all the ones that are being done outpatient as well?
Both, and when I mean, and of course, and when I say caught up, that means, everybody has some orders that are in progress all the time. So it's never that you have 0 orders pending.
But you don't have like 500 statewide or something like that.
No, we're back down to.
So if it's done outpatient just means not in the hospital, but it does mean in the jail. So do you guys have a pretty robust in jail process, or because where are you going to put, so many of these men and women, there is no place to put them, but maybe there is where you are. I guess that's the question, my question. Where do you put everybody?
And by you mean the service providers?
You have somebody who is very, pretty sick, and they're sitting in the jail, and there is no place for them. It just seems that there's a huge number of people that I'm thinking about in my jurisdiction that I couldn't do outpatient, but it's too many to go into our local hospital. So they have to, they're just sitting in the jail. Is that what's happening in Tennessee?
Well, so in Tennessee, if a person's fairly sick and the outpatient evaluator sees them, the number one reason for referring someone inpatient is that they're experiencing symptoms of a psychotic mental illness, schizophrenia, bipolar disorder, or psychotic and delusional, and that's why they're incompetent. They'll refer them to a hospital, and we'll get them in within 60 days. It's right now we're down to like 30 days and 40 days in a lot of areas. They'll come in for their 30-day evaluation with the goal of having them stabilized and competent at the end of those 30 days. And then
the numbers are smaller in Tennessee, right, Dr. Fox? So we talked about this briefly when we had a conversation earlier, and they don't look like Georgia in that respect.
Population itself.
Yeah.
Okay.
Yeah.
So our statewide population is just under 7 million. Of people in the state. So, and we've got 550 beds. I've got right today, I've got 156 people in our state hospital statewide who are some forensic status, and that includes the not guilty by reason of insanities, the incompetent defendants, and the evaluations. And because they're small numbers, I think that's true. You can pivot much more quickly when your volume is that small.
So I guess it gets back to my thing though. Are there some that are a fair number of people that are being stabilized in the jail setting?
If about 65 to 70% of the people are not referred to a hospital, some portion of them are getting stabilized in the jail. They were experiencing symptoms of mental illness when they came to the jail, and either through the criminal justice liaison or just the regular mental health services provided in the jail, they're being approached and engaged in treatment in some way.
If somebody is found to be not, or in that first evaluation and not competent, they can still be restored in the jail.
They could be, yes.
Does that happen very often in Tennessee?
That happens less often in Tennessee. If they're going to respond, they're going to respond fairly quickly, or they'll need to go to the hospital. So of that 65 to 70% of people who are not referred to a hospital, the majority of those are not referred because they were competent the very first time the evaluator saw them. They had already been engaged in treatment upon detention at the jail as soon as they were booked. They started taking medicine.
Other questions? And I think Dr. Fox is also involved with juveniles. So Judge Jackson, if you wanted to.
Yes, I had a couple of questions. So your adult system and the juvenile forensics, are they combined, or you have, because I think in Georgia you have to be qualified to handle either juvenile forensics or adult forensics. Is that the case?
Our same agencies have the juvenile court ordered forensic evaluations as part of their contracts. And some agencies you have totally separate clinicians because you have the people with the adult expertise doing the adults and the people with the youth expertise doing the youth. I have some experts who work with both children and adults who can do both evaluations. That depends on their clinical background.
And with the juveniles, they're not in jail, so we can't lock them up.
Okay.
What about the community? The problem we have is that getting treatment and getting evaluations in the community, because a lot of the kids are indigent, they don't have insurance, and it's hard to get them evaluated. How do you guys deal with that?
So in Tennessee, under Title 37, which is where the juvenile justice and child welfare law is, the juvenile court has authority to order a mental health evaluation on a youth who is alleged to be delinquent. And that court order, and I will pay for it. I will pay, that's part of our contracts with those 9 community agencies to serve juvenile courts as well as the general sessions circuit and criminal courts. So the youth is not held responsible for that. The juvenile court ordered evaluations are very different from adult court ordered evaluations in that the adult court ordered evaluations are strict on competency to stand trial, mental capacity at the time of the offense. And we don't give opinions on things the court has not ordered us to do. The juvenile court ordered statute says the report shall indicate whether or not the youth is mentally ill or developmentally disabled, what, if any, treatment or rehabilitation would be recommended for this youth, where might you get that treatment or rehabilitation, and does this youth meet commitment criteria under any part of Title 33. Transfer to adult court is discretionary in Tennessee. One of the things a juvenile court judge must find is that the youth can no longer be rehabilitated in juvenile court and that they do not meet commitment criteria. So that's why those 2 items are a part of the juvenile court order evaluations. So all those youth can get evaluated. We only get about 350 of those. Before 2009, courts could either order them inpatient or outpatient. The law changed in 2009 to match the adult law so that everybody had to be done outpatient first. And our referrals for inpatient went to 0 because essentially it's just extremely rare. There is such thing as early onset psychosis and youth who need to go to a psychiatric hospital, but we're able to access those services through the crisis teams or the youth's child welfare benefits. They don't need to go to a hospital for a forensic evaluation typically. So all of them are done on an outpatient basis at this point.
What about treatment? I understand about the evaluations. The hard part is that it's getting them to go to treatment because part of it is voluntary. You can't make them go to treatment. You can't lock them up.
That's
and
right.
if they're not totally incompetent where you can have them committed, it's more like where we get caught in the gray area.
That's right, and we're in the same gray area. Those recommendations for treatment that come with the juvenile court ordered forensic evaluation is for the family to follow up with. And we can't pick them up and drive them to the door of the clinic. They have to get themselves there. And that's the challenge. So we do have some programs, we do have some contracts with similar agencies that are going to provide services to youth who've been identified as needing services. So they're readily available. They try and do that warm handoff between the youth service officers, which is what we have in juvenile courts in Tennessee, and the service providers. We have service providers who are contracted to provide these services. They're almost always trauma-informed cognitive behavioral therapy or family systemic therapy type programs present in juvenile courts so that families have a face and a contact number. But yes, there's an actual real gap between, okay, here's our recommendations for treatment and the youth actually going to and being in treatment.
I don't want to take too much of the time, but Tennessee in some ways is about like Georgia. In the metropolitan areas, maybe like Nashville and Memphis, you can get treatment, but in the rural areas like the mountains or whatnot, the problem is transportation.
Yep.
And having to drive so far to get treatment that whether it's not as practical or not.
Yep. That's it. We got communal health agencies that cover all those areas, but getting the youth to the door of the agency.
Thank you.
Yeah.
So we also have some state court judges on which handle misdemeanors. And I was curious about in Tennessee, whether there's a difference in the standards or the process for folks that have a misdemeanor charge versus a felony charge.
Well, there's a story there actually in Tennessee. And that's similar legislation in 2009. Life changed so that counties became responsible for the costs of forensic evaluation treatment for defendants charged only with misdemeanors.
Oh, interesting.
Basically, we had an assistant commissioner at that time who'd been with the Department of Corrections for many years. And as some of you, particularly the court order people, the judges know that there's a big deal in corrections in terms of state time versus local time and misdemeanor time and who pays for what and so forth. And our assistant commissioner at that time said, "What, you guys pay for misdemeanors?" And so that law changed. And so that meant that there were a lot of jurisdictions who might order outpatient evaluations for misdemeanors because they were just a fee for service and not that expensive. But we were billing, the going rate for a third-party payer for inpatient psychiatric services in 2009 was $450, $500 a day. So we were going to bill the counties $450 a day for an inpatient evaluation on someone charged only with a misdemeanor. That's $13,000 for a 30-day evaluation, or our average length of stay is actually about 22 days, so $10,000. And Shelby County and Memphis didn't change their progress. We billed them $1 million a year before. Other counties are trying to put gas in the school buses, so they can't afford that kind of stuff. So we had a significant drop. I mean, misdemeanor business was 33% of all our business before that, and it dropped to 15% at that point.
Oh.
So this past special session of the legislature, the representatives have decided, you know what, we need to go back to the old way. There's a lot of these. We also have done some studies, like Vanderbilt University, who does my Davidson County evaluations, actually did a study to find a higher rate of finding people charged with misdemeanors to be incompetent. And a higher rate of people with misdemeanors increased clinical acuity, which makes some sense when you think about it. If a person is still in the criminal justice system when they're charged with misdemeanors and they're a mentally ill person, and we haven't been able to divert them, and we're still prosecuting them for misdemeanors, they must be pretty sick at that point. We haven't been able to do anything with them to get them competent to do anything else with the case. So I suspect in the spring, our legislature is going to return us back to the state just paying for everything. Now, in terms of the standards and procedures, they've always been the same. It's the Dusky standard for competence. It's the same statutory standard in Tennessee for the insanity defense. It's the same experts that do it. They're part of my contracts. It's the same people and the same process.
Is the timing still the same, the 30 days? That you have?
The timing is the same. In Tennessee, if a defendant is still incompetent 11 months and 29 days after their date of arrest, then misdemeanor charges are retired. And there's no
retired. That's an interesting term.
Yeah. That's the legal people came up with that term. And I guess I'll have to ask them what the difference is between that and dismissed. And there's no time limit on the felony charges.
Okay. Other questions from other folks? Judge Key, welcome.
After a 30-day inpatient evaluation of a defendant, regardless of what they're charged with, the vast majority of them are competent to stand trial and go back to jail. My contracts with my community agencies have them still involved in those cases to follow up with the defendant when they return to the jail. If they're competent because they've been medicated while they're at the hospital, they are to assist in making sure the person stays competent by continuing in treatment. And our criminal justice liaisons can help with that as well. If a defendant is not yet competent at the end of that 30-day initial evaluation, the hospital will then recommend to the court either that the defendant actually meets judicial commitment criteria. It's not emergency commitment criteria, so the risk of harm doesn't have to be imminent, but it is commitment criteria for them to be committed back to the hospital for an indefinite period of treatment and so forth. Or if they don't meet commitment criteria, the court has the authority to order the defendant to participate in community-based competency training. And that is a part of all my contracts with all my forensic experts. So our, jail-based or community-based competency training is in every jail because it's in every contract with all my outpatient evaluation providers. We rarely have enough defendants that fall into that category in any jurisdiction to have an actual program. Like I was extremely impressed with the program that Emory is a part of in the Fulton County Jail. But we don't have that many defendants, even in Nashville, really, to run a group at any one time. So it's an individual case-by-case basis that our providers are following up with those cases. The number one reason for being incompetent to stand trial for a mental health reason is a psychotic mental disorder. The treatment for that is medicine. We do supportive counseling with them, reviewing their case with them, helping them understand how to work with an attorney, what the difference is between a plea bargain and pleading guilty and all that sort of so forth. But none of it's going to work unless we're also making sure the person is continuing to take their medication.
All right, what else? Dr. Oliver, Dr. Wright, you have anything you want to ask Dr. Fox?
Question just about community-based restoration. I mean, the big barrier that we have is people don't have resources, no housing, no family to support them in getting to their appointments. So we might think they're appropriate for community-based restoration, but there's no structure behind what they actually need. And I didn't know if Tennessee has something. I've heard where other states have, community-based homes for restoration purposes. And I didn't know if Tennessee had anything like that.
Tennessee does not have any housing dedicated to incompetent defendants for community restoration who've been released from jail, who are on bond. Our criminal justice liaisons in the jails will get people the housing they need if they're going to be released from jail and they're a mental health consumer. And then all the rest of the services as well, who their prescriber is, where their day program is, things like that. And my contracted forensic experts will then work with them to reach the person in the community, to engage them in competency training in the community. That happens a little more commonly with the defendants who are incompetent due to intellectual disability rather than due to mental illness. They get released on bond at a much higher base rate for reasons I don't really know. But then our Department of Intellectual and Developmental Disabilities are the one who's following up with those cases.
Thank you.
I had a couple of questions, and maybe I just missed a couple of things. The judge, or does the judge send he's in the courtroom, you think he may be incompetent. Did they then send I'm just trying to figure out the procedure as to how y'all do this. Do they then send the request, or you can explain it to me maybe how the procedure is that it gets from the courtroom to the evaluation and then to the determination?
Yeah, it starts with the court issuing an order under, Title 33, Chapter 7, Section 301. Because we have evaluators designated by the commissioner to serve the courts, all the courts know who their providers are. So the orders go to the same email every single time and the same provider every single time. Send the court order, send the affidavits of complaint, and it'll be on the books and get scheduled. Then if the outpatient provider sees they need some more information, they'll chase it down and that'll be part of the process. But that's how it gets started.
How long does that last? I mean, how long does it take to get, to get the provider out there to do the evaluation typically?
My contracts have them do it within 30 days.
Then 30 days.
Or communicate with the court as to why it's not happening within 30 days. And that's where I let them sort of work things out case by case and court by court with what's happening with each individual case.
And is the individual always in custody?
Almost always in custody. Not always. We have folks on bond who have to come to the community mental health agency or connect with us with video conferencing.
Okay, so all right. And then the other thing, and I don't know if it was just a term of art y'all use, you have the criminal justice liaison. Is that an actual title in Tennessee, or is that just a word that you use for an individual in the courthouse?
That's a program in Tennessee. Our department contracts with community mental health agencies. The people who are criminal justice liaisons are case managers Some of them
Okay.
are licensed social workers. Some of them are working on their social work degree, but they're still case managers, so they're still bachelor level. But they're employed by a community mental health agency. Specifically, part of their job, if not all of their job, is to work with the folks in the jail.
Oh, thank you.
Anybody else?
Hey, Judge, this is Herb Cranford, if I can jump in.
Yeah.
So I was interested in the procedural aspect of this as well. So just to make sure I'm understanding this, because this sounds, like something I would like to see done at least. So a person's competencies brought to the judge's attention, the judge does the order, and then there's a person who is contracted with a local mental health agency who is responsible for getting them evaluated within 30 days, or if not, saying why.
Right.
Right. And so, and I think you gave a percentage earlier, but do you know of those initial evaluations, what percentage of those come back as found to be competent, like after the initial round of evaluation?
Yes, it's between 65% and 70%.
And I think that's consistent with the Georgia numbers from what I
It
recall.
seems very similar to the numbers we've heard, yes.
Yeah. And so my speculation is that 30-day turnaround is the difference between Georgia's 1,000-person backlog or whatever the number is, and Tennessee's lack of backlog. And because also to the extent anybody's doing it for delay, like a defendant's trying to delay, it doesn't really get them much of a delay.
Right.
So I think just kind of human behavior would cut down on that as well. But so, all right, thanks.
Hi, I have a couple of questions. Nikia Sellers. You mentioned, I think you talked briefly about that persons with a mental health illness and with an intellectual developmental disability are treated a little bit differently. I think you briefly mentioned that. If you could explain that a little bit more. And I also had a question about the criminal justice liaison in the jails and sort of what that looks like on a really practical basis. Like in the jail, is there, how do they, just what that typically looks like on a very practical basis. Those
Sure.
are my two questions.
Okay,
Yes.
sure. Yeah, so in Tennessee, if there's concerns about competency for a defendant, it's the same process on the front end. The court issues the same court order to the same provider for the outpatient evaluation. Should a defendant be considered incompetent to stand trial due to intellectual disability, my evaluators are now trained to do what we call an ID assist, an intellectual disability assist, to request assistance from the Department of Intellectual and Developmental Disabilities, because there's a separate statute in Tennessee which allows a court to either commit a defendant incompetent to stand trial due to intellectual disability to their facility, or to order that defendant to participate in outpatient competency training. So if you snooped around in Tennessee law, it's Title 33 is the mental health law. Chapter 7 is where this forensic mental health law is. Chapter 5 is where the intellectual disability law is. And so I've got people in the Department of Intellectual Developmental Disabilities that have gone through my same forensic evaluator training and have that certification, who then pick up and do the competency training on the intellectually disabled defendants. Much more common for them to be in the community rather than in jail, but they'll see them in jail if necessary. Much less common for them to go to a facility because it's a stable condition, which doesn't respond to immediate treatment and so forth and get better and come right back out, sort of thing.
Okay.
And then
I'm sorry. I think that's a difference between Georgia and Tennessee. I don't believe the statute addresses people with an intellectual disability.
It doesn't.
They sort of just lump them together with persons who have a mental health illness and intellectual disability. So that is a distinct difference,
Mhm.
I believe. So, okay. And then the next part, I'm sorry.
Yeah, and then I'll just mention that it's about 1% of all cases fall into that category of needing intellectual disability assistance. In terms of the 2,300 that we do per year, it'll be 40, cases like that. For criminal justice liaisons, how it looks, I think an important point is how it looks varies greatly from jurisdiction to jurisdiction, depending on what's best for that jurisdiction, what they're more comfortable with. So at the Davidson County Adult Detention Center here in Nashville, they have their own offices there in the jail. And they have keys and badges like the deputies do. They dress in scrubs rather than in uniforms. And that's how you know they're different. And then there's a separate mental health service as well. So Davidson County Sheriff contracts with WellPath to do their medications and things like that. In a rural jail, the deputies and the sheriff will know that it's Shirley from the Community Mental Health Agency, who's their criminal justice liaison. They may not have space for Shirley to have an office there, but when she comes, they know who it is who's coming there and what she's there for, and can give her access to detainees as needed. So it can vary from place to place. But what's essential is a relationship between that Community Mental Health Agency and that Sheriff's Department in terms of what services the Community Mental Health Agency wants to offer via contract that we're contracted with them to service, and what the sheriff is open, willing, and able to do.
So the mental health service is different from the criminal justice liaison, is what you're saying? Okay.
Yes.
Okay. That's interesting. Okay.
So sheriffs will have a legal obligation to provide basic health care and mental health care to anyone in their jails for the same kind of reason. So many of them will have their own staff, but most of them will contract with someone. Used to be Support Solutions, now it's WellPath, folks like that to do that's what.
Okay.
I do have some up east jurisdictions. Frontier Health is actually the service provider in some of the jails. As well as has the contract for the crisis team, as well as has the criminal justice liaison, as well as has my forensic evaluations. And so those guys are seamless in terms of their communication, who does what.
Okay. Thank you so much.
All right, anything else for Dr. Pikes before we thank him and let him get back to his work? It's very enlightening to hear about what's going on there. Yes, it's very helpful. So thank you so much. All right. I think you can go. Marilyn, I hope you'll stay on. Okay, good.
All right. Very nice to see everybody. Thanks very much for the invitation.
Thank you so much for all of your information you provided. It was really helpful, really enlightening.
And then somebody who's got my email, send it to Dr. Oliver so that we can communicate and follow up as well.
Yes.
Thank you. Sorry.
Okay, so the next thing on the agenda is Dr. Oliver. And I'll tell you that Dr. Oliver has sent me a number of publications in the last couple of weeks, and you're going to get some of those too. I'm going to ask her to talk about them. But one of the things is called Eliminate the Wait, which is a document that Texas Judicial Commission on Mental Health and Texas Health and Human Services put together, which is an interesting document. Another one was something from 2011 that I'm ashamed to say I didn't know existed, and it is the Mental Competency Best Practices Model from the National Judicial College. Did anybody else know that that was out there?
I knew about it after you told me about it.
Yeah, well, yeah. So, I mean,
because it talked about jail restoration, so I had no idea.
No, so it's, it's 2011, but it's still very interesting, and it's 52 pages, so I don't want to, spend a whole lot of time during the meeting, But I can say there's a lot of good information in there, and I hope we can use that when we're coming up with some recommendations. And then the other thing that she sent me, which was fascinating, and especially now that she's the director, is some strategic planning that she has going on. And so maybe she'll talk a little bit about that, but we'll hope to share some of that in the next couple of weeks with everybody as well. So Dr. Oliver, you're up.
Thanks for everyone for all the well wishes on the job change. I appreciate the support. Just to correct, the strategic plan was something that Dr. Wright and I developed back in April, where we were trying to plan on what we needed to do to fix some of the issues as we saw them. And I think we're willing to share that it was not put in like a publication worthy format, but it was just to spark ideas and conversation. So we could maybe clean that up and get that out to you. Some of the things on that document are already underway, so we're making some progress. Other things we weren't really sure what we could do within a department to implement some of those ideas. So I think we need to have some further discussion on those, but some of them would cost money, which we didn't know if we would have access to, and others we thought were under our control if we just organize the right people to develop some of those things. So I guess we can discuss some of that more in future meetings. But today I wanted to talk about the Eliminate the Wait document that you will get in the near future. It seemed like this was the perfect committee to start working on it. So what Texas did in understanding that they had a large backlog of evaluations and people waiting for the hospital, and their system is much larger than Georgia's, so their numbers were very extreme. But they brought the stakeholders together to look at how everyone contributes to the backlog in forensics. And I think that Georgia is in a place where we can do this. I think everyone here recognizes that we all play a part in the forensic system, even though DBHCD is responsible for carrying out the evaluations and treatment piece. But so thinking about if everyone could just look within their discipline and what they do, maybe we could come up with a very similar document to Texas to say best practices in Georgia, CSBs should look at this, police should look at this, the judges should look at certain things, prosecutors, other things. So really just putting together work groups to look at how everyone contributes to the backlog and what can be done reasonably to reduce the number of orders or people referred to forensics when really diversion might be the goal for the person instead of prosecution. And I think that this is a great committee to start that work, since it has people from all disciplines. We can look at identifying people outside of what Texas did. I mean, I don't know if we want to include probate judges or things like that, but I didn't think it was my decision to make, but I thought if we could just get it on the table here for discussion, we could probably create something very similar that works for Georgia.
I really think it would help everybody too. It would, it's really well written in that it gives you the reasons for some things, but it gives you sort of a checklist for each discipline, which is very helpful. And I think we do want to include our probate judges. The two are not here today, but I know Judge Harris would be willing to be involved, and I'm sure Judge Johnson too. So we'll get them involved. But my thought was, and this is based on working on the COVID task force when we were doing stuff, was that we put together this bench book. But we don't want a bench book. I'm not asking everybody to do that because that was a lot of work. But I'm asking everybody to take this Eliminate the Wait when we get it. And so it says, like, for instance, what's my role? And it talks about police. So we don't have police on our group, so maybe we won't include them. Maybe we will and try to get somebody involved. But it will say judges. It will say jail administrators. It says who else is the prosecutors, defense attorneys. So it has all those. So what I want everybody to do when they get this document is pull out the piece that applies to you. And then I'm going to be saying, Judge Porter, Judge Bruton, can you guys look at this from the perspective of a state court judge and come up with what it looks like? Judge Key, Judge Jackson, can you look at it from a perspective of a juvenile court judge? And what kind of document would this look like for you? for Ms. Sellers, did she leave? I don't know, but Ms. Sellers and Mr. Cranford, what does this look like for prosecutors? You're here. And the same thing, we don't have our defense attorneys on today, but same thing for them. And then and Judge Friesman and I and Judge Jarasoff, she's willing, we'll look at it from the perspective of a Superior Court judge. And then I expect Judge Oliver and Dr. Wright, Judge Oliver, did I just call you Judge Oliver? Dr. Oliver and Dr. Wright can help us with the pieces from DBHDD. But I think it's a great format. And so it would be helpful for us to have a format to start from, because I truly have been a little flummoxed about how we were going to get started. And this is something that would really help us, I think, get started. This piece and then a legislative piece where we talk and we look at the statute and we say, these are some things that need to have the statute. I hope to talk about that piece at our November meeting. But this piece, I'm hoping we get us started now. I want everybody to look at it and then have some ideas going forward. And then I will just sort of keep in touch with you this month and see what kind of progress you've made. I'm going to let you talk to each other about that. So, because I do think we should split it up like the judges. I think we should split it up into Superior Court, State Court, Juvenile Court, Probate Court, so that it's specific for each court. What do y'all think about that idea? Everybody willing to do the work?
It's a great idea. That's a really good idea.
Okay.
I want to also be fair and say that Dr. Risby, who's also DBHCD, he couldn't attend today because he got called to another meeting. He put in work to edit the Texas version to a Georgia version. But what I thought was that is from a DBHCD standpoint. So maybe we let you all look at it from Texas, have your own ideas and see how that aligns with what DBHCD was thinking in terms of each discipline. So that was my thought. Not that we're trying to withhold that document from anyone, but you're welcome to see it if you want. But we thought you would come up with the best ideas for your area.
Yeah, and I think you will as soon as you see it. And it's not really long. Like there might be 2 pages for a discipline. So I mean, it's not like we're saying you got to write a book for each group. So I am interested right now in the group that's here on 2 questions. One is there was an effort made in the legislation last year, and I think we've already discussed this, that didn't pass, to make the presumption outpatient evaluation. Does everybody remember that? That was an effort in the, what bill was it? House Bill something. I can't remember. But
520.
what?
520.
520, thank you. And so that bill didn't pass. I wanted to hear if there's anybody here that has a strong inclination that we shouldn't be going in that direction. Because I think maybe that is something that we could look at that would be very helpful. Judge Jackson, I saw you unmute immediately.
What was the question again? Because I think I do. What was it?
Okay. Okay, so the right now, the Georgia statute, the presumption is it's going to be inpatient evaluation, right? The effort was made last year to try to flip the presumption to outpatient, as we just heard from Tennessee, what they have done since 1974. So what I wanted to hear was philosophies here about worries. I mean, from my perspective in Superior Court, I would be fine with that, and especially if we add jail-based as part of that, so that it's clear that jail-based is one of the ways you can evaluate. But I wanted
That's my view.
Yeah, okay.
But Judge Key can join in, but the problem is with juvenile court, there's civil offenses. So there's no jail-based treatment. It's going to have to be out in the community. And that's part of the problem that you have, especially in the rural communities, more so than in the metropolitan. So, and as you know, some of the counties have more resources that they apply to.
Right.
And by having it outpatient, we need to figure out a way for the state maybe through the Department of Juvenile Justice to have those crisis units,
Mhm.
got like a circuit to make sure that the services are equally provided. Because what you have is you have some counties or circuits that you don't have any doctors and any resources, they have to go a long way. And whereas if we're trying to minimize it, if the state provides the services, then you have a more equality about the state. But almost, I would think 99% is going to be outpatient unless the doctor rules that they need to be committed, which hardly ever happens.
Okay, and so I'm not familiar with, the juvenile statute is separate from the adult statute in Georgia, so I'm not saying I'm familiar with what the presumption is in the juvenile statute to begin with. Is it the presumption?
Am I pretty close to it?
Yeah, there is no presumption out of the juvenile statute.
Okay. So, well, that's something for the two of you to come up with when you look at this and see if you can have an idea about what that should look like, taking into account both the rural and urban, I guess.
And Judge, I was just wondering exactly, I was looking for that exact language in the statute. Is this in 17,730 where the presumption is inpatient?
The presumption is kind of subtle in the statute.
It's subtle.
Yeah, it's very subtle. And what I'll do when we send out this eliminate the wait, maybe we can come up with the language. Marilyn, can you help me with the language that was in 520?
Yeah, I don't know it offhand, but we could track it down.
We could pull it down. And so I can send that to you all so you can see the difference. It took me a while to figure out what the language change was trying to do. And then I finally figured out that it was trying to flip the presumption. I don't think we need to be subtle. I think we could be, just direct about that in whatever legislation we want to suggest or recommend or whatever, whatever language we want to say. Because I just don't like the idea of us being too, why do we want to hide the ball? Let's just say what we want to happen if we think that's the way to do it. So, and that would.
Yeah, Judge, this is Herb.
Yes.
Sorry. I just want to piggyback on what you said that if the presumption were changed to outpatient and we explicitly said outpatient includes people incarcerated in jail, I would personally be comfortable with that. And I strongly suspect all the DAs would be on board with that. And I don't pretend to know what killed that legislation last year, but I'm guessing it was a public safety related concern,
Well, that legislation was much bigger than just that. And it had, if you listen to some of the public hearings, my head was spinning. So when I did talk to Commissioner Tanner, he said this group, our little forensic advisory committee, whatever recommendations that we want to make for legislative changes, he would try to bring to the fore just us, not put it in a bigger bill, not, as some sort of overall large mental health bill, but we would have some specifics. So, and he has a plan, I think, for meeting with legislative council and then trying to find sponsors. So, so I think we might have better luck. I don't know. You never know what's going to happen in the legislature. So we'll see. But I think we should be specific about what we want and direct and try to make it clear. Part of the problem with the code section for the adult is that it's not really clear, is it, Judge Friesman? No. So we would like
mud. The one thing I'm sitting here kind of struggling with a little bit is this, because I think it was a paradigm shift for me. I guess I wasn't paying enough attention before, and I did not realize the definition of outpatient or inpatient. And it didn't occur to me that this meant that then because what we're talking about then would be the standard would be, instead of in the hospital, doing it in the jail, doing a lot more restoration in the jail. And I don't know whether I think that's good or bad. I'm kind of struggling with it right now as to whether I do think that's good or bad. I know that you're going to get a huge, I don't know how powerful the sheriffs are in our state, but I'll bet you're going to get a huge backlash from them.
Well, we'd have to talk to them about what that means. It sounds like there's a
Yeah.
much more robust mental health system in the jails in Tennessee. And when we first talked to Dr. Fox, I was like, they must not have very many jails. We have so many with so
Yeah.
many different sheriffs. And
I mean, we're talking about trying to do some inpatient restoration in our jail right now. We're real excited about it, but I've never thought of that as anything except trying to fix my backlog, not that this was going to be the standard. So I don't know. You know, I'm thinking.
well, maybe that's something we should explore more. And
Yeah.
maybe Maryland can help us find some other states and some thoughts about that. Maryland.
That's what I was just thinking. I wonder if we could get some like data from some other states that are doing this about like, is this resulting in longer jail times or shorter jail times for the people that are waiting for competency to stand trial? Like, what does this actually mean for the data? Because then you can, use that to really decide how you want to move forward. So
Okay.
we can do I'll do some poking around, see what I can find.
Because one of the things I'll say one more thing, and I don't want to hijack this thing, but one of the things was always concerned me about in jail, different from the hospital. I remember I asked Dr. Oliver at one point, what was the magic that, why is it when you go to Georgia Regional, all of a sudden somebody who is spreading feces on the wall at the jail 3 days later, or 2 weeks later was back at the jail fine, and of course some of it was the medication, but also a jail, their first priority isn't mental health. Their first priority has and must be safety. And so they are looking at security. They're looking at it different. And I don't know, I'm not enough of a jail expert to understand how you arrange it so that there's safety there.
Well, so interestingly enough, in
Good
that,
for mental health patients, I would think.
right, in that mental competency best practices model from the National Judicial College, they say this works in jail evaluations if there are mental health pods, and
Right.
only if the jail has that, so that they have something specially available in their jail to make sure that people are, kept from the.
And we're getting ready to do that right now. So I'm going to get a
Right.
chance over the next couple of months to see what one looks like. And I don't know whether I'm going to be happy or sad about it, but
Mhm.
that's why I'm sort of, I don't know, the jury's still out with me, and I know we don't have a whole lot of time. So I know we don't have several months for me to
No, unfortunately. Well, I do think that this committee will last beyond this year. I think we'll come up with whatever we can for this year, but I think in talking to the Chief Justice, he seems to think we'll last for next year too. So we may have some more time to do more. And this may not be something we decided that we can do this year. I don't know. I don't want to push. I have some ideas, but not necessarily push. So I want everybody to look at from their own perspective and see what they think is important for us to recommend this year.
And I also will state that I think we made the definition of outpatient, it would be a total shift, at least speaking from Fulton County, thinking about outpatient restoration, because that is something that it seems like the criminal justice partners here have understood to be in the community and not in custody in the jail. And even some of the evaluations that we received, those initial evaluations stating if someone is competent or not competent, when the doctors make their recommendation for inpatient or outpatient competency restoration, they will specifically say inpatient restoration because this person does not have a history of attending appointments or having basically community support, housing, a regular doctor, or and they have not had haven't had a history of having support in the community for their mental illness or going to regular appointments. And so the suggestion is for inpatient, specifically saying inpatient treatment, such as the jail restoration program. That's
Right.
the language that's used. So I understand the difference. Mhm.
One of the things that other states have done, have just said jail-based restoration is separate from inpatient restoration and outpatient restoration. Jail-based restoration is just another category. So I mean, Mr. Cranford said it could be part of the definition, but it also could be just a separate third way. And then we also, we need to remember and keep in mind that we're talking about two different things, evaluation, and then we're talking about restoration. So maybe we have different ideas about the evaluation versus the restoration. So I think we need to keep all of those, and that's sort of what you were talking about, Ms. Sellers. The restoration is really separate from where you do the evaluation.
Okay. And so so if it's saying outpatient evaluation, is that what the definition we're looking?
We can also say
It could be
jail-based
jail-based.
evaluation. I mean,
Okay, jail-based evaluation.
we'll look and see what some of the others say, but I think how we do it is less important than that we include it as a possibility. Whether we put it under outpatient or whether we say it's a separate category on its own. And it's being done. So so we need to make the law sort of fit what we're actually doing at this point.
Absolutely.
So in some places we're doing it. All right, I didn't really have anything else because I thought one of the things we'll be doing is I'll be following up during this month with you once you get the documents. But I did want everybody to just express any concerns or issues. I think if we focus on the issues that we've been talking about, like can we put together a document that will be recommendations for each discipline? And can we put together a list of legislative things that we hope to achieve in this next upcoming legislative session? That's probably all we can achieve in 2 months. So, but this seems achievable, especially since we have this blueprint from Texas to help us start. Questions, concerns? All right, well, I think we're done a little early from our timetable. Judge Friesman, you unmuted.
I was gonna say, so the big thing that you're asking for us right now is to go through the draft, that draft toolkit from our different perspectives. And
Well, I want you to take the eliminate the way Texas one. Yeah, not the draft one, but the
okay, I'm sorry, eliminate the waste. Okay.
the Texas. And Judge Friesman got it early because I sent it to her, but y'all are going to get it soon, right? Dr. Oliver, we're going to get this out to everybody.
Okay.
Maybe Ashley can send it afterwards. She can send the Texas document, the mental competency best practices model. That is, light reading for the beach. That's 52 pages. And then Dr. Oliver and I are going to meet on Friday to talk about the strategic plan and maybe come up with some ways that she and Dr. Wright can make that a little shorter.
I was uncomfortable looking at the judges and court staff page because I know that the judges couldn't possibly have anything to do with any of the problems that we have. And so I couldn't imagine what would be in there. And there were things.
Well, one of the things that I've just started doing just since we started this is now when somebody asks me for an evaluation on somebody, I say, we're going to have a hearing. You got to tell me why, because they rarely put anything in their request. So we've started setting hearings and I have my first one next week. So. And there's a colloquy about how I'm supposed to actually talk to the defendant. We'll see if I do that, but at least I have to say somebody has to give me a reason for this, not just that it popped up on the trial calendar and whoops, I wasn't ready for trial.
Yeah.
Okay. All right. Thank you all for taking some time out of your day. I appreciate it very much. And the thoughtful questions that were asked and comments, very, very good. Where the next meeting is November, what is the date? November the 15th. Is that right, Ashley?
It is. Yes, that's correct.
Okay. And we are having a tour of which hospital, Dr. Wright and Dr. Oliver?
Atlanta Regional.
Atlanta Regional. I think we're having lunch. I can't remember the time. It was like 10 to 12:30 or something, or 1:30 or something. Anyways, we will have a tour and lunch, and we'll have some discussion about what we've been talking about today. Hopefully. Okay, and I hope we'll have another meeting, but I didn't really want to set one because until everybody's there in November and has a firmer grasp on their calendar between then and the end of the year. Okay. All right. Thank you.
Thanks, everybody.
Thanks. Bye.
Grab.